Have you ever been in therapy and then felt the spark and thought, oh crap, what does this mean? Or maybe you're a therapist and a client says something and suddenly you freeze in your chair. Because I don't know about you, but this wasn't something that was really covered well in graduate school. Well, today we're talking about erotic transference, what it is, why it happens, and most importantly, how both therapists and clients can deal with it without shame and without derailing the work. Now, just a quick disclaimer before we get started. You should always consult with another mental health professional, a supervisor, or your local state board if you have more specific questions or concerns in this area. Trust me, it's always a good idea to be proactive and have an extra set of eyes on these kinds of situations. Okay, disclaimer out of the way, let's get into it. Erotic transference is when a client experiences romantic, sexual, or deeply idealized feelings toward their therapists. It's not rare. In fact, in psychodynamic and relational models, it's often expected because therapy is an intense process in an intimate space. The key thing to understand is that these experiences are symbolic. They're often about past attachment experiences, unmet needs, or defenses, not about the therapist's real dateability. And here's another term that you may have not heard before, mutualization. This is basically when the therapist reciprocates or acts on those feelings in some way. Now, ethically, that's a hard no. In the professional frame, it's never okay for that to happen because it changes the whole purpose of therapy and can potentially do harm. How so? Well, handled poorly, erotic transference can actually cause shame, ruptures, or even trauma. And just in case we're unfamiliar with what a rupture is in therapy, it's any strain or breakdown between the client and the therapist. Like when a comment is made or a disagreement happens or a silence goes on too long. Just things that make the client feel hurt, misunderstood, or less safe to open up. Now, when erotic transference happens, it doesn't mean that you necessarily have to disentangle and refer out. For clients, it doesn't mean that it's necessarily the end of therapy with that therapist. It's a signal that something important needs to be addressed, and handling it appropriately can strengthen the bond and the therapeutic growth. More specifically, it can open the door to conversations about vulnerability, boundaries, and how we relate to others. Now, for my therapists out there, if you'd like some strategies on how to handle these situations well, here are 6 steps backed by research and good clinical practice. So the first thing that we need to do is to reaffirm or reestablish the standards of confidentiality, ethics, and that therapy is a space for expressing and exploring any feeling, but not for acting on them. The second thing we need to do is to name it and normalize it. I love the sayings, you gotta name it to tame it, you gotta speak it to tweak it. So just say it plainly. This is something that can happen in therapy. Let's understand together. That kind of a statement reduces shame and opens the door to meaning making. Now, in step 3, we need to assess the safety and the function or the utility of the behavior. Is the erotic energy a bridge to vulnerability or a defense against it? Now, here's why that distinction matters. Sometimes this is coming from a place of real vulnerability. In other words, a client might be opening up and showing you for the first time how much they long to be seen, accepted, and cared for. This can lead to very deep work about shame, attachment wounds, and broken trust. Now, other times, the sexualized energy is functioning more like armor. It's using excitement, intensity, and even chaos sometimes to keep the therapists on their toes and avoid having to really be vulnerable in therapy. Now, in that case, the attraction becomes a defense for having to face painful emotions, trauma memories, or their insecurities about being rejected. Now, if a client is repeatedly testing boundaries, for instance, flirting, steering the conversations towards sexual topics, or creating situations where the roles are blurred, my first suggestion is to slow down. Don't match the escalation with more interventions. Instead, stabilize the framework of therapy, take the heat out of the moment, and build some space for reflection. And this is the point where if this happens, supervision isn't optional anymore or consultation, it's essential. A fresh pair of eyes can help you to see blind spots, clarify risks, and decide whether it's appropriate to proceed and adapt the treatment approach, or in rare cases to refer out. Because there are situations where clients have a history of multiple boundary violations in relationships, and the therapy room can be another sort of arena for them to reenact those dynamics. Sometimes they're in acute crisis or trauma processing, and eroticized transference could absolutely destabilize them. Or, especially in forensic, mandated, or other dual role contexts, the risk of misinterpretation and harm is just too high, and the best thing that you can do is to transfer care. Now, in these cases, keeping the work ethical and safe means pacing more slowly. It means reinforcing boundaries more explicitly and making sure that you keep your support networks engaged. Now, getting back on track, the fourth step is to work the meaning, not the magnet. Explore the client's interpretations of the situations by asking a question like, when I set a boundary, what story do you tell yourself about me, about you? Also be sure to track your own countertransference. Pay attention to your own physiological cues, avoidance, overdisclosure, or fantasies about specialness. And again, this is another spot where consultation saves careers. And last but not least, document and plan. Write down what happened, the risks that were considered, and the rationale for continuing or referring out if safety can't be maintained. Okay, now if you're a client, here is how you can work with this in a way that keeps therapy safe and productive. The first step is to say it out loud. This is not something that's going to get you into trouble. It is your therapist's role to help you explore your feelings, not judge them. Step 2 is to get curious about the timing of all this. Do these feelings show up after being seen, after conflict? The pattern matters. Step 3, name your story and expectations. What I mean is, whenever you notice these feelings about your therapist, ask yourself, what is the story my mind is telling me about this situation? For example, if they really knew me, they'd fall for me too. They only care about me because they're paid to. Or, if I don't keep them interested, I'm afraid they'll leave. They're not just random thoughts. These are inner scripts that we've learned from our past relationships, sometimes dating all the way back to childhood. And when you name that story out loud in therapy, 2 powerful things happen. Number 1, you take it out of the shadows. Instead of acting on it automatically, you gain the ability to consciously observe it and decide to do better with it. And number 2, you invite your therapist into the pattern. That gives you both the chance to explore where it came from, how it's shaped your relationships, and whether it still serves you now. So instead of getting stuck on, oh no, I'm attracted to them, what do I do? Try shifting to examining the meaning behind this attraction and talking about that in therapy. Now in step 4, you both need to co-create boundaries. Agree on a session structure that reduces ambiguity. Things like greeting rituals, the check-in process, or what the policies are about communication. Tidying those kinds of things up can help your brain to stop sort of the misinterpretation process and allow you a safe space to continue working on addressing these feelings. And lastly, in step 5, ask for repair. If boundary setting feels like rejection, say so. It's a chance to heal those old patterns and learn how to manage them constructively instead of falling into another spiral. Now, for everyone watching, referrals should really be our last resort. They should be used when boundary violations keep happening, risk escalates, or the therapist's feelings can't be managed with support. And if it happens, it should very clearly be framed as protecting the therapy, not as a way of punishing the client. So always lead with intention and be clear about what your goals are. And for further reading, I'll post some additional links in the description below. Remember, erotic transference isn't a mistake, it's information. With strong ethics, curiosity, and support, it can lead to breakthroughs instead of breakdowns. Thank you so much for watching. If you found this helpful, please share it with a friend or a colleague who you think might need to hear it. I am Dr. Charles. As always, stay safe, take care of each other out there, and we'll see you at the next check-in.